Hello, everyone. This is Dr. Siddharth Tambar. Welcome to our webinar today. Before I begin, as a reminder, as I'm going along, please enter your questions. I'll answer live, whatever comes through. And after we're done, you'll have a chance to watch this in replay as well. And if you have any other questions afterwards, please contact us either through our website or any of our social media channels. And let's get started. Thank you for showing up today. So today's talk is on regenerative medicine for inflammatory arthritis. I think the title of the talk originally was, regenerative medicine for pseudogout. And so I think pseudogout, it's one piece of inflammatory arthritis. And so I sort of expanded it to inflammatory arthritis in general. And we will run through that. So what you'll get from this webinar is you'll learn more about non-surgical treatments for arthritis and tendinitis that do not require surgery, what works in regenerative medicine, how to choose the right regenerative medicine treatment and physicians for your condition, and where does regenerative medicine fit in inflammatory arthritis conditions. Again, after we're done, or at any time, you can always contact us via website or social media channels. So just briefly about who I am, my name is Siddharth Tambar, physician here at Chicago Arthritis and Regenerative Medicine, specialist in rheumatology and regenerative medicine, specialist in image-guided musculoskeletal injections, in practice since 2008, in practicing regenerative medicine as well since 2008, and within the Regenix Network, which is the largest group of affiliated physicians working within regenerative medicine, sharing protocols and ideas about trying to get the best results for our patients. Just a little bit more about me. My journey into regenerative medicine starts with my own shoulder. I played a lot of tennis when I was younger. As I got older, even before I had any shoulder pain, when learning musculoskeletal ultrasound, found out that I had some mild chronic rotator cuff issues. That got me thinking more and more about tendon and ligament injuries, realizing that we didn't have enough good options there, which then got me thinking about joint injuries as well and joint pain. And just looking at other options, which eventually got me involved in PRP, Prolotherapy, then bone marrow cells, and how to combine that in our patients who have not only traditional wear and tear and injury issues, but also inflammatory arthritis. So traditional care for pain in general is pain medications, traditional injections like steroids and nerve blocks, just masking the pain, waiting for eventual surgery. And surgery has a lot more risks than non-surgical options. And what can we do that avoids surgery? So looking for better options. These options should be low risk, avoid serious side effects. They should address the actual source of the problem, which is instability or inflammation. They should improve the actual cause of the problem, again, whether it's instability or inflammation, so that you get more longer-term improvement. So as a rheumatologist, how do we think about regenerative medicine? All right, there are dozens of different types of arthritic conditions. Inflammatory arthritis is a type of arthritis where there's dramatic inflammation, and that's systemic. That's a systemic condition, meaning the total body is affected. On the other hand, you have degenerative arthritis and tendinitis, which is more about instability, which tends to be more of a local condition. The keys in either case are that you want to treat the cause, which is either instability in wear and tear arthritis or inflammation in inflammatory arthritis. So in regenerative medicine, we're essentially using your body's own cells to treat your arthritis, tendinitis, injuries, and back pain. And so in that normal healing process after an injury, take, for example, a cut on your finger, you have platelets come in, they stop the bleeding. They then release growth factors, which then starts an inflammatory process, stimulating your own local mesenchymal stem cells, which then brings in other cells and growth factors, which then starts a normal cellular healing process. So that works great in tissues with good blood flow, not only skin, but even muscles. In tissues that have less blood flow, they tend not to heal as well. That can include tendon, cartilage, ligaments, disc, labrum, meniscus. Those tissues can be very hardy and resistant, but after recurrent injury or severity of injury, they can not heal very well on their own. So regenerative medicine is the process where we are using your own cells, either your own blood platelets, your own bone marrow stem cells, inject that into tissue that's been damaged to coordinate that normal healing process in tissue that's not healing very well on its own. So the good thing here is that this treats the source of the problem, which can be instability frequently and sometimes inflammation as well. Safer than surgery, effective for most musculoskeletal conditions. And for those of us that are really deeply involved in this kind of care, we feel like eventually 80% of orthopedic surgery will switch over to these kind of treatments. In the same way, the vast majority of open heart surgery is now handled with needle-based procedures and medications. So inflammatory arthritis is different than wear and tear or degenerative arthritis. The source of the problem in inflammatory arthritis is inflammation. In autoimmune conditions, it's the immune system is not working correctly. What I mean by that is that your immune system, which is meant to normally protect you from bacteria and viruses, now for whatever reason is misfiring and is starting to be overly active and is attacking your own body. So conditions that would include are rheumatoid arthritis, psoriatic arthritis, ankylosing spondylitis, and lupus. And these conditions are ones where the immune system is dramatically active, causing total body inflammation. Then you've got crystal arthritis conditions like gout and pseudogout. Gout is a condition where your body is not metabolizing uric acid properly, which leads to an oversaturation of uric acid, which then leads to crystallization, needle-like crystallization, and then eventually deposition into the joints and sometimes other tissues, leading to inflammation and then an overreaction by your immune system. Again, pseudogout is a similar process, but now you're having calcium pyrophosphate crystals that are depositing. You can see that in conditions like hemochromatosis, hyperparathyroidism, where there's too much calcium, right? So you can see that in a few different types of conditions, and in some cases, just some people are just more prone to that. The keys here are that, how do you treat inflammatory arthritis? For autoimmune issues, rheumatoid arthritis, psoriatic arthritis, when the condition is so many joints that are active, dozens of joints that are active, there is so much good data that you use medications that control the immune system to actually control the overall condition. For crystal arthritis, for gout, use a medication called allopurinol that helps to reduce your uric acid level, that helps to prevent gout from happening. Pseudogout, we don't really have a similar medication. So in general, it's utilizing anti-inflammatory medications as needed, sometimes borrowing medications from other conditions to treat the chronic inflammation as well. It's not perfect because we don't have a really great disease-modifying treatment. It's more about trying to control the condition. Generally, this approach works well. That's what's been around for decades. There are potential risks with these treatments, with all medications, but including some of the immunosuppressant medications, which is why it's always worthwhile asking if there's other options. So a good question to ask is, and question that I hear patients ask, is could regenerative medicine help in the setting of inflammatory arthritis conditions, whether that's pseudogout, rheumatoid arthritis, or anything else? In theory, there are some regen med options that may be helpful. Alpha-2 macroglobulin is something your body already makes. We can concentrate that after a blood draw, and it's a very strong anti-inflammatory that can be re-injected into the joint. Interleukin-1 receptor antagonist protein is another similar, very strong natural anti-inflammatory that your body makes that we can concentrate and then re-inject into the joint. Interleukin-1 receptor antagonist protein, just as a little bit of perspective, was actually the treatment, the plasma treatment that Kobe Bryant, the basketball player, was getting when he would go to Germany every summer for a few off seasons in between his training and season. Platelet lysate is something that we do frequently right now. It's growth factors from PRP or from blood platelets. It gives you the same benefit of PRP, but without the inflammation. Interesting. Bone marrow concentrate does lead to more inflammation short term, but has a high concentration of mesenchymal and hematopoietic stem cells, growth factors, and platelets, and long term can actually reduce inflammation as well. So these are all interesting options that could work in inflammatory arthritis conditions. You need to understand that what is the data for regen med treatments in inflammatory arthritis? It's very limited currently. There are case studies showing some benefit. There's animal studies showing benefit. In humans, there's only case studies right now. So my take is that your first line treatments, if you have a total body condition, should still be to treat things on the total body level. And that includes disease modifying treatments and biologic medications, because that's what's been around for decades, and that's where really most of the data is. Regen med treatments could still be considered, but as a primary treatment for inflammatory arthritis is still considered experimental. Important to understand that. So what are some practical uses of regen med in inflammatory arthritis? This is how I would consider it. Number one is first, control your systemic inflammation. If you are, let's say, a rheumatoid arthritis patient and you have 20 to 30 joints that are active, I would recommend taking the appropriate medications to control the overall inflammation. Then, if you still have some remaining other musculoskeletal issues, those can still be treated. Whether you have some chronic osteoarthritis, tendonitis, chronic ligament instability, or nerve entrapment conditions, that should be treated with regen med treatments. And in reality, our inflammatory arthritis patients have much higher rates of these other conditions. The reason being because of that chronic inflammation, you start to develop some damage in the joints, the ligaments, and the tendons. And even after the inflammation has come down, those structures are still a bit weakened and more prone to more damage, which is why you see patients who have chronic inflammatory arthritis have chronic degenerative arthritis as well. So in that case, even though you've treated the chronic inflammation, the chronic instability and degenerative issues are still active, and those can respond very well to regenerative medicine, and I would recommend that. Some other practical uses, every once in a while you'll see a patient whose inflammatory arthritis is very limited. Let's say someone who only has 1 or 2 joints that are involved. That's someone you could consider a regenerative medicine treatment. Obviously, each patient's a little bit different. You need to make sure that they're not at high risk for progression, in which case medication should still be considered strongly. Again, on the other hand, let's say the systemic inflammation is controlled, but there's still a couple of joints that are active. Even in patients who've got chronic inflammatory arthritis, they do really well with treatment. Some examples would be an RA patient. I've seen RA patients that come to me who've got dozens of joints that are active, and they're asking about, can they utilize bone marrow stem cells? And I'll always tell them, get the inflammation under control first before we consider that. And in those patients where total body inflammation is controlled, and they still have 1 or 2 joints that are a little bit problematic from a little bit of inflammation, some wear and tear arthritis, they do great with treatment, whether that's bone marrow or platelets. Another possible practical use would be in patients who have a contraindication to utilizing traditional medications that we utilize for inflammatory arthritis. And those are patients who have still active disease, but they can't take traditional medications. And we need to take a more creative, even experimental approach, then regenerative medicine still remains a really good option. Let's talk a little bit more about regenerative medicine, some of the basics of regenerative medicine. These are things that are important to understand if you're looking at treatment. And these are some basic concepts that I think are essential for all patients to understand, whether you have inflammatory arthritis or not, if you're considering a regen med treatment. This first concept is stability. There's this concept in architecture called tensegrity, which means that if you take individual units that separately are weak, if you put them in close approximation and compression, you now have a structure that's much stronger. This concept in medicine and biology is called biotensegrity. So prolotherapy is the idea of injecting your own cells into those soft tissue supportive structures around a joint or tendon that's been damaged. Treat all the different layers that are there to support that joint. And if you do that, you can strengthen the supportive structures, which then leads to progressive strengthening over time of that unit, which then gives better pain relief and functional improvement longer term. Prolotherapy, that's the concept of prolotherapy. The traditional prolotherapy that was used since back into the 1950s was using solutions like dextrose or sugar water in a high enough concentration to create a mild irritant to start that normal healing process after inflammation or an injury. A more advanced version of prolotherapy now is utilizing your own blood platelets, your own other kind of cells from your blood, and your own bone marrow concentrated stem cells to treat tissues that have been damaged, to support them, to strengthen them, to improve stability and reduce inflammation long term, to reduce pain, improve function long term, and improve overall quality of life. Prolotherapy tends to be dextrose prolotherapy, traditional prolotherapy with sugar water tends to be milder. In general, it'll take monthly treatments for 3 to 6 treatments. PRP is where we take your own blood and get the platelets from that. That is a stronger treatment, generally repeating treatment every 6 to 12 months. And bone marrow-derived stem cells are an even stronger treatment, and generally we're repeating treatment every 2 to 5 years. It's an example of someone who had ankylosing spondylitis, which is a chronic autoimmune arthritis that can affect the spine. They've had, and their inflammation is under control with medication. The thing is that they have also developed some chronic wear and tear. And again, we see that frequently in someone that's had prior inflammation in a joint. That joint has been slightly damaged. Some of the supportive ligaments or tendons have been slightly stressed and weakened. And now that person has developed degenerative wear and tear issues in that joint as well. In this patient's case, he had degenerative disc disease in his L3 to L5 level. He'd had prior surgery, he was still having pain. We see that frequently. In his case, we first tried platelets, treating all those areas, the ligaments, the facet joints, the muscles, and epidural space. He had a mild to moderate response to begin with. We escalated to bone marrow stem cells, and he's doing dramatically better. What's nice about this case is to understand that you can have inflammatory arthritis, you can also have degenerative arthritis, and treating the degenerative part, even after the inflammation part's been controlled, can be very helpful. And seeing how platelets can work and seeing how bone marrow, which is stronger, can work even better. Orthobiologics. These are the cells that we utilize in our RegenMed treatments. Again, utilizes the body's normal healing process. I strongly recommend using your own cells and not somebody else's. The reason why is dramatically safer. The vast majority of data that's available in regenerative medicine comes from using your own cells and not somebody else's. We've been talking about platelets, platelet-rich plasma. The key initiator for really normal healing after an injury, utilizes that inflammation pathway short-term. Important to understand there's a difference between short-term inflammation after an injury that is meant to heal after an injury versus chronic inflammation where something is off with your body, either off from an autoimmune standpoint, a metabolic standpoint, something else is off that's causing chronic inflammation. Chronic inflammation is not good. It's your body's inefficient way of trying to improve things. Acute inflammation is a more healthy way of your body trying to heal things. Injecting platelets into an area that's been damaged creates a micro-inflammatory process there, not total body, just that one area. Stimulating your local mesenchymal stem cells, it starts that normal healing process. There's different types of platelets. That picture on the right shows an amber-colored or yellow-colored platelets. That's what we're aiming for. That's platelet-rich plasma, very high concentration, without any red blood cells, so it's less inflammatory. That's the one we'd recommend injecting into joints, tendons, ligaments, and around nerves. And then you've got the platelet-rich plasma on the right, which has a lot of red blood cells. We don't recommend that one. That one can be helpful in muscles, but in other areas, it tends to be more inflammatory. There's also something called platelet lysate, where we take that amber-colored platelet-rich plasma, crack open the platelets, and just take the growth factors. That's even less inflammatory. We like that around nerves in particular. It's an example of a knee tendonitis individual. And this is someone, when we say tendonitis, we're talking about irritation of the tendon. And frequently, when we think of tendonitis or arthritis, we say, oh, there's some inflammation in that area. There is a little bit, but it's not inflammation like you see in an autoimmune condition, all right? That is a different kind of inflammation. So this is someone who's got chronic tendonitis and patellar tendon. The picture on the right is of a tendon. Not sure if you can see my cursor here, but the hyper white line is the bone. That's the patella, the kneecap. This long structure is a patellar tendon, and where you see these small bone spurs is where the tendon is tendinopathic, meaning irritated. This is a picture on the right where the needle is injecting directly into the tendon and where it's been injured. He had 2 platelet treatments, PRP treatments, and he was able to get back to his full activities. I saw him 3 years later for his other leg now, hamstring injury. Again, treated that and doing great. What I like about this example is nice to show how platelets were great for tendon-related issues, soft tissue issues. In addition, nice to show how repeat treatment is helpful and treating again for another area can be helpful as well. The next orthobiological to be aware of are your own mesenchymal stem cells. So your stem cells in tissue are the ones that drive the main tissue repair recovery after an injury. Strongly recommend you use your own cells, not somebody else's. Understand in the United States, the only stem cell treatment that's legal with living cells are your own bone marrow-derived stem cells. Fat cells, fat stem cells, you may have heard about this, are not considered legal in the US. And the reason why is because the enzyme that you need to break apart all the connective tissue in fat is considered illegal to be used in humans in this country. The FDA has concerns about human exposure to that. You can get that in other countries, however. In this country, you can get versions of fat where it's sort of pulverized or microionized so that you have, it's not really a stem cell concentrate at that point, but it's an adipose product, fat product that has some stem cells, some other growth factors. Very helpful if you're trying to treat tendon injuries that have been torn. You may hear about amniotic and umbilical cord cells. Please understand that there's no living cells in those when given the United States. In other countries, they may be using tissues that haven't been quite as aggressively processed as they are here. You may be getting some living cells there. Some potential issues with that in terms of giving somebody else's cells to your own body. You may hear about things like exosomes. That's another one. Exosomes are small packets of growth factors that come from stem cells. It's an interesting idea. Again, almost no evidence of its utility in human use currently. Maybe something to consider long-term, but currently not really ready for prime time. IV stem cells are things you may hear about as well. No definitive proven benefit for orthopedic conditions. I've had a couple patients who've gotten that in other countries. They felt like it helped out their overall inflammation temporarily, but then eventually that came back. I don't recommend that as a primary way of trying to treat your joint issues because you're really better off injecting that into the joint directly. When it comes to decision-making for RegenMed treatments, we need to think about what's your severity of your issue in terms of, are you amenable to treatment? What treatment should we use? Bone marrow for more advanced things, platelets for more moderate things, and prolotherapy for more mild things. There's always some potential medical contraindications that your physician should be thinking about. Understand that you may get one treatment, let's say a bone marrow stem cell treatment. A couple of years later, you may get a booster treatment. That may not be stem cells, that may just be platelets. And of course, keep in mind cost as well can affect some of your decision-making here. In terms of outcomes, things to understand, and I'll show you some pictures in a moment, but yes, we can definitely improve pain and function, even if you have advanced arthritis. Cannot reverse damage on X-ray or MRI if you have advanced arthritis. If you have a tendon or ligament tear, as long as it's less than 2 centimeters, we can actually make that improve on imaging as well. If you have swelling in an arthritic joint, we can obviously reduce that long-term with your own cellular-based treatment. And if you have an early case of what's called avascular necrosis where the bone is being damaged, that can be reversed as well, and I'll show you some pictures of that. Can we treat bone-on-bone arthritis? Simple answer is it depends on the joint, but for the most part, yes, especially knees, especially if range of motion is still intact. Hips, if you've got more advanced arthritis, can be more difficult, but if your range of motion is still intact, we can still improve chronic inflammation, still improve stability. Cannot get your knee to look like or your joint to look like what it was when you were 18 years old, but we can certainly improve your pain, function, and stability. So can we treat tendon and ligament injuries? This is a ligament case, an ACL injury for the knee. This is a younger man. He's a butcher. He's not a professional athlete. Tore his ACL while playing volleyball. He had bone marrow concentrated stem cell treatment a few months after his injury. At the 3-month mark after treatment, he's doing great, restarting dynamic activity. It's exciting is imaging here. Picture on the left is an MRI of an ACL tear. I hope my cursor can be seen. But there's the bottom of the ACL. As you go higher up, it becomes very hazy. You don't really make it out as well. It's been read out as a complex partial tear or possible full tear of the ligament. It's not that the ligament is fully pulled apart. There's still a little bit of room here to treat. So this is 3 months later after his treatment. Now you have an ACL that fully intact, still a bit of fluid, right? Still a little bit of swelling, but this is being described as essentially a normal looking ACL now. So exciting result in terms of not only pain and functional improvement, but also in terms of imaging improvement. This is a case history of a 57-year-old man, full thickness tear of his rotator cuff. The images on the left, top and bottom. This is ultrasound. This hole is a big tear in the rotator cuff. That's a full thickness tear. We treat him with his own bone marrow stem cells and platelets. This is 3 months afterwards, doing much better clinically. Now you see where that big hole was. Now there's filled in structure there. He's still doing great a few years after treatment. I think he's actually like 5 or 6 years down out of treatment now. Next concept to understand is what's called interventional orthopedics. This is using image guidance to treat orthopedic injuries. I've got colleagues who believe that you can inject joints and tendons just by feeling the outside of the skin. It's very 1950, 1940-ish. In this day and age, if you have X-ray and ultrasound available in the office, you should be utilizing that during all interventions where you're sticking a needle into the body, in particular into joints and tendons and spines. So these are some examples of injecting into the shoulder. Left one is an ultrasound image injecting into a rotator cuff tear. There's a needle, small little tear. This looks big on the screen, but the reality is that is maybe 1 to 2 millimeters by 1 millimeter, very small. Picture on the right, X-ray image injecting into his shoulder. Again, there's a needle. What you see lighting up is the shoulder joint to make sure we're in the right spot. Even more interesting is we previously also injected the labrum, the superior labrum. That's a triangular structure that's lighting up. To do that blindly, almost impossible. You really do need image guidance for that. I showed these pictures before. The one on the left, ultrasound injecting into the patellar tendon. Picture on the right, injecting into the ACL. A case study for avascular necrosis, ankle avascular necrosis, 41-year-old man. He has a history of gout and osteoarthritis. So his main issues, the picture on the left, it's a pre-treatment MRI. He has fluid in the joint. He's got degeneration of the joint as well. And he's also got swelling of the bone. This swelling of the bone, if we don't treat this, will eventually get progressively damaged and damage the bone even more and progress the arthritis. So we injected his own bone marrow stem cells into the joint, the ligaments, and into the bone. 3 months after treatment, you see the fluid is pretty much gone. And now you also see that that prior swelling of the bone has resolved as well. So exciting that we've not only helped him out with his pain, his function, but by treating that bone, we've now actually preventively stopped progression of his condition as well. Regenerative medicine treatments offer safe and effective solutions for your pain. Let me pause and just catch up on questions here. Okay, good. Again, after we're done, you can always contact us afterwards to learn more or to schedule an appointment. Is this too good to be true? Philip Hernigue talks about, has been doing studies on, he's an orthopedic surgeon in France who's been treating shoulders and knees with bone marrow comparing to surgical patients since the mid-90s. Regenetics Network has data since 2005. I have colleagues who maybe 5 to 10 years ago were saying that they didn't think these treatments worked. And now they're telling their patients, maybe it works, they're still not sure. The reality is that while this is a rapidly developing field, it's not new. For those of us that have been doing this for a while, and for me, it's been 17 years, I can tell you that there's right and wrong ways. Your expectations should be grounded in reality. If you've got other medical issues, whether it's inflammatory arthritis, pseudogout, rheumatoid arthritis, diabetes, cancer history, heart history, anything else, diabetes history, your doctor needs to be able to understand all of that, how it impacts your condition, what is safe to use, what's the right treatment to use at that moment, because what's right for you might not be right for another patient, and to then give you the best possible result. How long do results last? Philip Herding has data that goes over 20 years. Regenix has data that goes over 15, almost 20 years now. I still tell people, if you have a chronic condition, expect a repeat treatment at some point. That might be, let's say you get a platelet treatment for moderate osteoarthritis in the knee. Maybe we're repeating treatment in 2 to 3 years. If you've got bone marrow stem cells for, let's say, again, a knee, you might be getting a repeat treatment in 5 years, right? Just have an understanding of how these treatments work, and that repeat treatment, generally speaking, most people will get an improvement, slow improvement over months, and they'll stay at that level for some time. That might be for years, it might be for multiple years. And at some point, there may be a little bit of step down, and when that happens, getting a repeat treatment now gets you back higher. You don't really ever go back down fully to your baseline. You may dip a little bit, and that's when repeat treatment gets you up. The best way to maintain results after treatment: improve your biomechanics, take the right supplements. Again, repeat treatment is additive in that stair-step fashion to initial treatment, and maintain your ideal body weight, especially for lower extremity and back issues. Reason why is every pound above ideal body weight will increase the weight on your lower extremities and back by 4 pounds. So if you can do that, makes a big difference in terms of pain as well. So what makes a regen med expert? I think they need to be a musculoskeletal expert, meaning they shouldn't be dabbling in it. They shouldn't be doing 5 other things. They should be focused on that. Should be non-surgical expert. Our surgical colleagues are very well trained in surgery. They don't have the fully right training on the non-surgical side for these kind of treatments. They need to be an expert in image guidance. I think that's where a lot of our orthopedic surgery colleagues are lacking. Because when you inject these kind of cells, you cannot be just close to there. You have to be precisely in that area, 1 millimeter by 1 millimeter. Otherwise, you're not going to get the right kind of outcome. They need to understand how to use inflammation to help you heal. Acute inflammation with these treatments in a localized way is fine. Chronic inflammation is the problem. They need to understand the different types of biologic treatments that are available and that we can utilize for you. They have to offer you a personalized approach rather than a one-size generic approach. They need to understand that concept of prolotherapy and treating all those other structures around the joint to improve stability. They need to understand and be transparent about potential results and your candidacy for treatment. Are you a good, fair, or poor candidate? They need to be willing to follow your treatments long-term, not just doing a procedure and you never see them again. And they need to be able to guide you through the process and answer your questions. Because these treatments, they're not brand new, but they're still newish. And I think I think it's common that people would have questions and need to be guided through the process. And your physician should be able to do that. A little bit more about us here at Chicago Arthritis and Regenerative Medicine. Focus on non-surgical treatments for musculoskeletal issues, arthritis, tendonitis, injuries, and back pain. Focusing on inflammation, instability, asymmetry, neuromuscular issues. Correcting with low-risk interventions if possible. If not adequate, then escalating to regen med treatments if appropriate. Using the best products from you, a plan that's specifically tailored for you, and delivering your cells using the highest level of image guidance possible. If interested in getting evaluated, you can go check us out at chicagoarthritis.com. Again, please contact us either via the website or social media. We're here to help and answer questions. Okay, wonderful. Let me just run through one more time, see if there's any more questions here. Okay, great. Well, listen, everyone, thank you for your time today. If you found this helpful, continue to follow up with us on the website and social channels. If you have any other questions, please contact us. If you want to be evaluated for an appointment, go to chicagoarthritis.com and connect with us. Thank you, everyone, for your time. Until we connect again, have a good day, and I hope everyone stays healthy and lives well. Bye-bye.